Hey, hi. Welcome everyone to today's webinar. My name is Phoebe Spry-Bailey. I'm one of the trainers from Turning Point. I'm in the workforce development team. And yeah, just want to welcome you all along. And yeah, today's topic is on women in substance use disorder treatment, gaps and challenges for clinicians. Before we go on any further though, I would like to acknowledge the traditional custodians of the land upon which we are presenting on today and pay our respects to Aboriginals, elders past, present and emerging. We're very excited to be here today, as you'll probably notice from the new platform that we're working on, that we've had a bit of a refresh here. So I'm just going to take you through what some of the functions you might be using today. As you all know, those that have tuned in the past, when we've done webinars, we like our webinars to be as interactive as possible. So there's still the function to be able to ask a question. So you'll see the little hand up sign that you can press on. And then we have, if you want to download the slides that our presenter will be talking about today, they're available in the download resources. And then, you know, if Redback, you want to put out any notifications, they'll sort of pop up on your screen. And then we also will have, at the end of the webinar, we'll have a feedback survey. So that'd be really great if you can feedback to us about, you know, how you found the webinar today, because your feedback is always really important to us, and particularly if you have any ideas for future webinars. And yeah, so but anyhow, just you can all practice with, you know, with your mouse in front of you and hover over all those little icons that you see. So that'd be great. And today's webinar is going to run for about 45 minutes. Feel welcome to ask questions throughout, but we will be taking the questions at the end. So the presenter and myself. And yeah, but and before I go on any further, you know, I would just like to, you know, welcome our presenter, Shalini Aranagiri, and she's an addiction psychiatrist and our clinical lead at Turning Point. She's the chair of the Binational Faculty of Addiction Psychiatry at the Royal Australian New Zealand College of Psychiatrists and a senior lecturer at Monash University. Her research background includes a PhD on risk markers for methamphetamine psychosis and investigating treatment models and targets for women in recovery from addictive disorders. So we're really lucky to have her along today, and I'm, you know, really interested in the topic that she's going to be presenting on. So at this stage, I'd like to hand it over to Shalini, and yeah. Great. So welcome, Shalini, and thank you so much for taking the time out, because I know it's busy time of year for everyone.
Thanks very much for having me along, Phoebe. We might get started. So I apologise to anyone because we're starting a little late. It's a problem with inviting a clinician to do a talk, unfortunately. So morning clinic runs late, everything runs late. Without further ado, we'll get started. We've got a few slides here, but you should be able to download them as well. So if we have to run a bit fast at any point, hopefully you'll be able to catch up. And as Phoebe was saying, you know, if there are any questions, send them through and we'll try and make sure we've got some time at the end to answer them all. So we'll get started. So today we're talking about women in addiction treatment, and we're talking about women presenting largely to Australian treatment settings. But really today's webinar is focused very much on sort of clinical treatment for people with addictive disorders. We're not going to really be talking about kind of broader presentations for people who just use drugs but don't necessarily have a disorder. And I think that distinction is important. And over the course of the presentation today, I'm going to take you through some of the literature that underpins some of the evidence in this area, but also really highlighting that there is really probably a paucity of evidence in this area. And it is an area that I'm personally very interested in, but I think has had a lot of burgeoning interest in the last 5 to 10 years or so. In terms of treatment approaches, that's where we'll spend a bit of time at the end talking about what the evidence is for different types of treatment approaches for women as opposed to men in treatment services. And we'll have some resources at the end as well that you can read up more if you're interested on. So before we get started, just a word about the distinction, I guess, in the space between gender and then sex. So we're talking largely today about sex rather than gender. So sex refers to the biological differences rather than gender identity per se. and that distinction is important. And I said today most of the talk focuses on sex rather than gender, in the sense that many of the social factors that I'll be talking about later are largely applicable to people who identify as being female as well. So we're just moving on to a poll now, and we'll just pull that up on your screen. You should be able to see that come through now. And the question for you in the audience is, what proportion of people accessing Australian publicly funded treatment do you think are women? And so we've got a few different options there. It's not a trick question, but hopefully if you want to just send through some of your answers, we'll see what we're actually going to come up with. Just a few more people getting their answer through, hopefully. Yep. Just looking down, it's popping up on our screen there. I'm just going to give it a few more seconds, and if you're holding back on your answer, that's fine. We'll move on, but maybe if you don't want to give me the answer, that's also okay. So we're having a little bit of two popular choices that are quite spread, actually. So just keep going, but basically the choices are split at the moment between options B, C, and E. So some options there between 30, 40, and 60%. And so I think, I'm not sure if you can see that up on your screen at the moment, but essentially the three most popular choices in the group today are between 30, 40, and 60%. So the latest data, that's from the treatment surveys back from last year, and that's the latest data that we have across Australia, is that 32% of people accessing treatment in Australia are women. That's been pretty consistent for the last 5 to 10 years, really. And so option B in this case would have been the correct answer. But it's interesting that we do have a disparity of opinions, and it probably also reflects where we personally might work if we're clinicians, or the perspective that we might have. But across the board, in publicly funded treatment services, you're looking at about a third of people accessing treatment are women. Of that group, about a third of people are citing their primary drug as alcohol. And then the next most popular option in terms of primary drug is methamphetamine. And that's been a change. So I'll take you through the next few slides, which look at the statistics for Australian treatment, and just give some credit to my research assistant, Davinia, for preparing a lot of these slides as well. So this information is from the Australian National Minimum Dataset, which you can look up at the AIHW if you're interested. And here we're looking at Australian women seeking treatment as their primary drug of choice. And as I mentioned, alcohol has been the most cited primary drug for some time now. So this is looking over the last decade. And amphetamines then are the next most popular option. Now you'll see some big changes there in the last 10 years in terms of amphetamines and how that's actually really increased as being a primary drug. In the 5 years really leading up to this last little period, that's been a drastic increase for amphetamines in women, and there's also been an increase in men, but the proportion of people seeking in women has nearly tripled, whereas in men that's nearly doubled. So in terms of age groups as well, in terms of women seeking treatment, women who are currently seeking treatment tend to be older, and we've seen a real big rise in the recent period over women who are over 60 years old as well. And so those are a growing demographic. And now if we look at comparisons between men and women who are seeking treatment in the last decade, you'll see that that 1/3 of the proportion as we voted on in the poll, that's really been reflected for some period of time, that the vast majority of who presents services are men. And then if we look at what the primary drug is by men versus women, again you see the same spread with men in terms of alcohol and amphetamines being up there. Cannabis is more commonly cited as a primary drug for men than it is for women, and these are raw numbers here, so they're not proportions of the total when you're doing that comparison. But overall, the drugs that people are actually presenting to treatment for are by far and away alcohol, and then followed by methamphetamine and cannabis to some extent. So in terms of a summary of Australian treatment, what we know is that there are rising rates of women presenting to treatment services over the last decade, and increasingly people are seeking help for methamphetamine use, more so than men, so 3 times more than they used to. And there's a growing proportion of women who are older seeking treatment. So hopefully that kind of is concordant with your own reflection in treatment services as well. So we've largely been talking about treatment now, and I'm going to move on to talking a little bit about research. So in research, the majority of both research conducted on humans, on adults, as well as animal research actually, is also conducted on mainly male populations and male samples. And there's a range of reasons for this, why this occurs. In animal studies, that's largely because there, until very recently, has been no requirement for studies to actually include male species. So for instance, in studies that have been performed on rats or mice, they've almost entirely included only male rats or mice. And so the reasons there are varied reasons, but one major reason is because the sample doesn't then have to account for variation by menstrual cycle or estrous cycle. And so, that actually means that a lot of evidence that's kind of drawn from that space that then follows on to adult human research may not necessarily apply to females. Then if we look at research that's conducted on adult humans, again, many of these studies are recruiting from clinical populations, so they're recruiting from treatment settings. And as we've just seen, that's largely composed of men. So by and large, many studies that have recruited from clinics are going to be recruiting men. That's more convenient, but also there's some logistical barriers to conducting studies on women, in the sense that women might be primary parents, they might have childcare requirements, they might not be able to attend appointments during the day, during school hours, for instance. So that all of these considerations have an impact on recruitment. And there might be confidentiality barriers in terms of child protection or concerns around that as well. The other barrier to recruiting women into trials has been around clinical trials not wanting to recruit women in case of pregnancy. So that's really something that's come up in the more recent period where that's not been a valid exclusion. And this has really been led by changes in the US that have required now that clinical trials need to include women by default. And if they're not going to include women, both animal studies and human studies need to make a justification as to why they're not including females. But that's a relatively recent thing. So this is just an overview of some of the studies that have been conducted in Australia, research studies. And again, this just highlight that these are the studies where we draw a lot of our evidence from, so both in terms of what psychological treatments might work, what medication treatments might work, also what we expect from people's recovery process to be like. And many of these studies, as you can see, are largely conducted in primarily male samples. Interestingly, the largest proportion in those list of studies that has been conducted on women has been in the POINT study, which is recently concluded, and it includes a group of people who are using prescription opioids. And that's certainly something we'll talk a little bit more about today, but that is a group where women are overrepresented by and large. So in summary, what we're highlighting here is much of our evidence, in terms of evidence that comes from research on what works in addiction treatment, hasn't necessarily been tested for safety or efficacy on women as much as it should be. And so this is where we really kind of start to think about, are the treatments we're offering to women, do they work as effectively for women as they do for men? And how do we know that? And that applies to both psychological and medication treatments in that space. So I'll just grab a drink of water while we move on to the next section. So we're going to talk a little bit now about what the differences might be between women and men in addiction treatment. So there are obvious differences. So women and men are biologically and physically different, and physiologically there might be reasons that underpin problems with addiction, but also socially and psychologically, depending on the culture and the society that the person lives in, men and women have vastly different experiences across their lifespan, and that can be salient as well. So some hypotheses that have been raised in sort of the literature and in clinical settings as to why men and women might have different sort of experiences with addiction are that it's an exposure issue, that more men use drugs and more men might be exposed to drugs, and that's why more men have drug use disorders than women. The second hypothesis is that once people start using drugs, that men are more likely to develop problems associated with their use, and that's why they're presenting more to treatment services. And then the third hypothesis is that more men might be seeking help for problematic substance use than women. So we'll break that down a little bit more. In terms of use and exposure, is that an accurate kind of hypothesis? Certainly across cultures, across societies, across countries, we know that more men use drugs and alcohol than women. But I'll start to raise a question here about that gender gap between men and women. And we know from lots of emerging literature that that gender gap is narrowing, and that there are specific trends on the rise in women. So this next couple of slides look at this website called Our World in Data, where you can map data across different sources. And here we have a whole range of different countries mapped on this slide. Just to explain the graph a little bit, on the left you've got basically the burden of men who've got prevalence of substance use disorder, and then on the bottom axis you've got share of females who have substance use disorder. And what you're looking for is points where it's an equal proportion of men and women with the substance use disorder, where it would sit in that middle diagonal line. And really, from my perspective, we can look at the screen here, the only country that sits anywhere near that middle line is Ukraine. But if you look at across the board, if you look at countries that we often draw our data from, our evidence from, for instance, United States, that's very far away from that equivalent line. And in the next slide, I'll just show you what it looks like for Australia and the rest of Oceania. And here we've got Australia quite far again above that dotted line. So what that means is really across the board, most countries, almost all countries really, have a much higher proportion of addictions in men than they do in women. But as I mentioned before, that gender gap is narrowing, and the first substance in which we've really started to see that happen is with alcohol. So I'll draw attention to this study by a group of people in Sydney largely, who did this large study looking at birth cohort trends in alcohol use and related harms. And with this picture here, you can see that basically it followed up a whole range of different people who were born in different periods of time. So you start off in the upper left-hand corner and then you move along the slide towards the bottom right. And people born in the upper left-hand corner versus people who are born in the lower right-hand corner, so in terms of older versus younger. You can see there that the proportion then of alcohol use disorders is actually getting closer and closer to that middle diagonal line, where there's an equivalent proportion of burden in both men and women. So the study had lots more interesting things to say about why this might be, and certainly if you're interested, go back and encourage you to read that study. It's open access. But really this was one of the first studies that kind of pointed to what's happening here, that they actually were starting to see newer generations an equivalent kind of proportion of substance use, in this case alcohol use, in both men and women. So there are other substances for which this is also becoming a question. I mentioned before a previous study in Australia that looked at women and had a 56% proportion of women in that study, which was around prescription opioids. So here we draw some evidence from the USA, where I think everyone's aware there's a prescription opioid crisis in the USA. And there are really a lot of burden of harms and debts in the USA associated with opioids. Now here, if we look at just prescription opioids, the burden of harm for prescription opioids appears to be largely overrepresented in women than it does in men in the USA. And nearly 48,000 women here in this study died of prescription painkiller overdoses between that last decade. And the deaths and the mortality rates in women are much higher than they are in men. So for every woman who dies of prescription overdose, 30 go to the emergency department as well. So you've got this really high burden of harm, in the sense that every 3 minutes in the US, it's estimated that a woman goes to the ED for a prescription painkiller problem. So this is a different problem than what we have here, certainly at the moment. We don't have that same sort of rates, but I guess it sort of starts to raise the question, why is this happening? Why prescription opioids, a particular drug that women seem to use more than men and have more problems with? There have been a number of different reports and studies that have started to probe that question. And one question is around just how the drug is obtained, so the exposure to the drug. And here we know that women, certainly in the US, have both an increased risk for chronic pain. There's a whole range of reasons why that might be, but there is an increased risk there in terms of women compared to men. But also in terms of exposure to have a prescription, to get the prescription opioid, women are more likely to be prescribed opioids for pain. They're more likely to be prescribed it at higher doses, and also more likely to be prescribed it for longer. And again, those reports kind of summarize that evidence really nicely if you're interested in it. So one possible hypothesis here is that studies have shown that women tend to use prescription opioids not just for the chronic pain itself, and the pain is a very subjective phenomenon clearly, that experiences of pain are often coloured by sort of psychological distress, mental health problems as well. And so women often report that the opioids help them relieve mental health problems associated with the pain, including anxiety and depression. And also with prescription opioid dependence, women have a higher rate of trauma, and certainly women with family violence have injuries that might require them to be prescribed prescription opioids. So that again increases that rate of risk in terms of prescription opioid dependence. So that's one thing to start thinking about in terms of the women who present to our services. Now we'll talk a little bit about other prescription medications. So there's a couple of images there that relate to advertising in medical journals in the last sort of 50, 60-year period. And this was something related to sort of phenobarbital. It was a very strong sedative. But here the ad is really about sedation without sedative days. And if you can read the script, it really kind of paints this picture about a histrionic sort of woman, apparently, where a moth seems to be a monster to this person. And so apparently one option there is to prescribe this person this medication to have more sedation. This is another ad, and this is for oxazepam, which is still a benzodiazepine that we prescribe regularly. And this ad was suggesting to doctors, presumably male doctors, I assume, that you can't set her free, but you can help her feel less anxious. And here, oxazepam is proposed as a solution for that. So this is not a new problem. Certainly, as we can see, for the last 40, 50 years, benzodiazepines and sedatives, broadly speaking, have been proposed as kind of a solution for distress for women more so than they have for men. And what we see is really in terms of harms associated with benzodiazepines. In the US, there have been a couple of big studies that have come out really suggesting that opioid use has an underpinning also related to benzodiazepine use, and that benzodiazepine rates have been going up for a long, long time. So I refer you to that study in the journal from the American Medical Association in 2015. And that suggested that 1 in 20 US adults actually fill a benzodiazepine script annually, but women are doubly more likely to do that than men. And in Australia, a recent study that came out just this year suggests that we have much lower rates of benzodiazepine prescribing compared to the US, about 1 in 60 adults fill a script, but that it's often co-prescribed with opioids, even in women. And here we've got 60% of that group were women, and more than 50% of them were older. And that's a group where we're going to see more harms and more risks as well. In terms of other drugs, very quickly just saying that quetiapine or Seroquel is associated with more harms in women than it is in men. Rephrasing that in terms of more harms are presenting through ambulance attendances, and in this study nearly 3/4 of those presentations were in women, and almost twice as more likely in women than it was in men. So moving on, we're talking about two different pathways that might differ between men and women. Basically, women across the literature are more likely to be introduced to their substance that they end up becoming dependent on through an intimate partner, and that's a really important distinction. And then the second thing that to draw on is this phenomenon called telescoping, where women are much more likely to have a progression of their illness more quickly into developing complications across a range of substances. So I was starting to get people thinking about this specific sort of service where we were seeing many more women presenting for treatment than we were for men. A complete kind of change from in terms of looking at face-to-face treatment services. And here, there's no face-to-face treatment service, it's counselling online. And here we have online counselling services that by and large see many more women than they do men. And really one question around this is the role of stigma in terms of that being a huge barrier in people accessing treatment services. So a range of studies have outlined this, and I've put one reference up there. But in the US, really, it's cited as the #1 reason why women with substance use with substance use problems don't actually attend treatment. In most cultures across the board, women with substance use problems experience more stigma than they do men. And there's a whole range of reasons for this, but generally what happens there is that women then feel like they're not deserving of help or treatment. And there can be a whole range of difficulties around shame and guilt and low self-esteem and self-efficacy that can then impact on the person's ability to kind of engage in their own recovery. The role of being a parent here plays a huge role across cultures, and shame and guilt about failure of that maternal role can really kind of impact on recovery as well. So in the next little bit, we're going to talk about physiological differences and how they impact on differences in use disorders, and we're going to go through each drug individually. And so this is just a summary of some of the main differences that can cause differences between men and women in this space. And here we're really seeing that body weight, body fat composition, water percentage, that can all play a role in how your body metabolizes a drug and whether you become intoxicated and how quickly and how long it takes for that to metabolize through your body. And then here we're also thinking about the role of sex hormones, so things like estrogen and progesterone, which play a role as well as being neuroactive hormones, so they actually play a role in the brain and how your brain metabolizes things. Pregnancy, obviously, and reproductive health play a key role in our understanding of the space. So bear with me while I go through a fairly medically looking slide. Here we're talking about the menstrual cycle, and this plays a major role in how someone actually reacts to the effects of substances, as we've only really found out over the last 10 years or so in terms of this literature. So at a half of the cycle, in terms of someone having a menstrual cycle, and half of the cycle, that's characterized by one hormone versus the other. So in the first half of a phase, you've got what's blue on the right, the estrogen phase, and then you've got what's green in terms of having a high level of progesterone. And so this is relevant because we've started to find that that actually does make a difference in terms of how the body reacts to substances and then how it copes with withdrawal. So taking you through a few different drugs, we'll start with smoking and tobacco. So in 2006, one of the first studies came out that suggested that women metabolize nicotine faster than men. So when they're smoking, they're actually getting through that cigarette faster than men in the sense of their body metabolizing it. And this might be one reason why women report not responding as quickly or as effectively to nicotine replacement therapy, so gums and patches. Quitting smoking can also be more difficult for women at some parts of the cycle compared to others. So in that second part of that phase of the high progesterone period, that can actually be a period where it's harder to quit. And you have higher withdrawal symptoms and people report having more cravings or needing more cigarettes per day. So that's important, I guess, when someone's queuing up a time that they want to look at a quit date, maybe starting to think about maybe where that fits in with their cycle might give that person a little bit of an additional ability to quit. Now, if we think about alcohol, the majority of literature that's been looking at sex differences has been conducted in alcohol. And here we know that in terms of intoxication, in terms of the effects of using alcohol, that actually happens at a lower blood alcohol for women than it does for men. So that threshold is lower. And that's mainly because of those physiological differences we talked about. We also know that across the menstrual cycle, people seem to respond to alcohol the same way. But we also know, because of that telescoping phenomenon that we talked about, that alcohol-related medical complications and mortality also happen at a lower threshold for women than they do for men. So they're more likely to develop complications earlier on in the piece. And that includes a whole range of complications, including cardiovascular disease, hepatitis, cirrhosis, and mortality as well. So that's really important, because if a woman's presenting in treatment and has been drinking for X number of years in a certain amount, we need to start screening for those medical complications earlier than we might in a man presenting with the same problem. Breast cancer risk is really salient here, and there's been a whole range of literature supporting this in the last decade. And now we've got a quantified sort of estimate around this that really every drink per day increases risk of breast cancer by about 10%. So that's across the board, regardless of what that threshold is for the number of drinks that person has. Keeping in mind that overall breast cancer risk in the population is low, but on top of that, you're increasing that risk with alcohol. And then if we think about cannabis, again, that phenomenon of telescoping is seen in cannabis, where someone can escalate from using occasionally to a lot, but also in that intoxication effect, that some of those effects are similar across the menstrual cycle and similar in women compared to men. But in some recent studies, that women actually have reported having higher subjective effects or more likely to actually continue using compared to men. And that withdrawal symptoms in women, some studies suggest, might be worse compared to men. And finally, looking at stimulants. So again, here there's been some really interesting studies that have suggested there's a variation in effects of stimulants across the menstrual cycle, and that in parts of the cycle, women have a lower response to a stimulant being given to them that's more similar to men, and then at other times of the cycle, they're going to have an exaggerated response. This has led to some more recent studies actually starting to investigate the role of hormones, such as progesterone in this space, to actually dampen the effect of the stimulant, so as a treatment. And so this is really a space that's in its infancy at the moment, but it's a very exciting sort of treatment approach that might be available in the future. Certainly when thinking about stimulants, there's also different factors that might impact on recovery. And one thing to think about here when you think about methamphetamine use is that fears concerning weight gain, and this is also salient to people quitting smoking cigarettes, that fears around weight gain can impact on recovery, certainly. So in terms of social factors, and here I think, I'm probably overstating the case. I think everyone is well aware of the severe clinician, that there's a whole range of factors that impact on women in society that are really relevant in terms of recovery from addictions. And I've just listed a few of them there. I think, many of these are tied in terms of why stigma is such a barrier for women. And I think for when you're seeing a woman, I think parenting, the maternal role that the person has, and childcare, and then concerns around loss of children play a huge role in terms of person actually presenting in treatment services, engaging in treatment, and then concerns around what might happen in treatment. So I think that's something that really deserves its own space and its own talk. But I think the other things that deserve their own space and their own talk are really around family violence. I think we've had a talk on this in the last year, but I think really understanding how this impacts on a woman's experiences through addiction treatment is really, really salient. Now we spend a slide just talking about prison settings. And in terms of the criminal justice system, this is in Australia, but this applies certainly internationally and much more so in the US than it does for us even. So in the US, 61% or more of women in federal prisons are actually incarcerated for drug-related crime, that non-violent drug-related crime. So it's hugely overrepresented in that space. And then in Australia, of the people in custody, of women in custody, there's been rising numbers of women in custody, and 1/3 of that group are Indigenous. And between 70 to 90% of that group of women have a history of trauma. So what you're seeing in that space is really that, and again, this is probably unsurprising to anyone who works in this field, but that, in terms of the Australian female prison population, a huge proportion of that population have a history of trauma, and a significant proportion will have a history of substance use problems. And so, what we're actually seeing here is something that's overrepresented in women that we don't largely address routinely. In terms of social factors, there are other populations aside from criminal justice systems where people are actually hugely overrepresented. Again, Indigenous Australian women are hugely overrepresented in the space. Also, regional and remote Australians in terms of a whole range of factors that impact on ability to access treatment. Clearly, the availability of treatment in rural and remote settings is one major barrier. But also, confidentiality can play a huge issue. You might actually know many of the people who work at your local drug and alcohol service, so you might not want to front in the door. And I think for us, on counselling online, we think that's one major reason why we see so many women with concerns around that. Being a distance-based intervention, that people can actually just call up or use counselling online and not be concerned about that. But stigma plays a huge role there. Certainly economic factors in terms of rural and remote Australia also play a role. So summarising that sort of space, I guess the patterns and trends associated with substance use certainly differ across the board in women compared to men. And I think what's starting to happen in kind of the addiction treatment space and research space is really understanding the public health effects associated with addiction are gender specific, and that we need to think about them in that way. And that the pathways to initiating and maintaining an addiction, but also the pathways out of addiction are distinct in women compared to men. Many of those factors are physiologically related, but certainly a vast majority are also socially related. Let's take a pause there while we move on to treatment, and certainly keep sending your questions through. We'll make sure we've got a little bit of time at the end to address them. In terms of treatment approaches, so I'm going to speak quite broadly around treatment approaches and not spend too much time in terms of particularly around pregnancy and breastfeeding, because again I think this is a topic that deserves its own talk at some point. I hope that some of the clinicians who are tuning in today work in this space and might be able to share their expertise perhaps through this forum. But I think this is really a huge topic in its own right. But I think I'm also wanting to raise some questions and some discussion maybe around models of care that might apply for women more so than men, and what are the distinctions there that might apply to women. So in terms of pregnancy and breastfeeding, I think what's really happened in the last probably 10 to 20 years is that we've started to understand that in pregnancy what doesn't work is punitive intervention. So what doesn't work is actually, once someone's actually presented seeking treatment, what doesn't work is actually, having the risk of child protection involvement impact on that treatment engagement. And what doesn't work in other countries is really incarcerating women, for instance, who present with pregnancy and substance use problems. So what we've also understood is when we address treatment in pregnancy, we need to understand that there are two people we're addressing, that the needs of both the fetus or the baby as well as the mother need to be considered. And so what's really important is balancing that need and making sure that the mother also gets their own needs and their own kind of rights addressed in that space. So with pregnancy and breastfeeding, I think what's really important to remember is our non-illicit drugs, our freely available drugs, alcohol and tobacco, are by far away the two most harmful substances to the developing fetus based on the evidence that we've got. They are the most prevalent, certainly in the space as well. And so if you're going to spend time, I guess, talking to your pregnant substance use seeking patient, that this is where that a lot of work needs to really be done in terms of helping someone understand the impact of both alcohol and tobacco. So a little bit of work is done in space, and Australia is probably one of the world leaders in kind of drawing a lot of this evidence together. But with alcohol, we know that, with smoking, we know that in 2010, for instance, this data suggests that about 12% of Australian women smoked in pregnancy. And this is much, much more common in Indigenous populations than in non-Indigenous populations. So this is really something that's a target for sort of treatment services to be able to help support women quit during that time. Less than half women actually quit during pregnancy, and of those women who actually manage to quit during pregnancy, up to 2/3 of people often go back to smoking after the baby's born. And there's a whole range of factors why this is really important as well. That's really well outlined in that study that I've referenced there, which is quite recent and again freely available. And that really highlights both the risks of smoking in pregnancy, but also post-pregnancy about going back to smoking. And those risks can include things like SIDS, for instance, an increased risk of SIDS if the mother is smoking. So these are things that are worth talking about with a woman, both when they're pregnant, but in that postpartum period. And there's a whole range of apps and other resources available out there to help someone quit during pregnancy, including the Quit For You, Quit For Two app. Quitline Victoria has other resources as well. But I think if you're working with people in the space, it's really worth spending some time talking about smoking. And then the next drug that it's worth spending some time is on alcohol. We know that there are really high rates of FASD, and it's probably significantly under-recognised. The most recent estimates suggest that there's about a 5% of the population prevalence in terms of FASD, which is really high when you think about it. And it's diagnosis of FASD, or fetal alcohol spectrum disorder, I should point out. The diagnosis of that has really been underestimated over time, and we're really only now starting to get better data on that. So that's a disorder that can impact on someone lifelong, and certainly many of our adult patients in substance use treatment services would have likely been at risk for it and would not have necessarily had that diagnosis recognised early on. So that's really something that we're only starting to understand a bit more about. There are a whole range of public health campaigns in this space, and that includes things that I've screenshotted there, like What Women Want to Know and Pregnant Pause. And again, if you work with pregnant women often, then I think this is a space that's worth kind of reading up a bit more about. A lot of our guidelines in the space come from the Women's Hospital, and I've screenshotted some of their guidelines there. The College of Obstetricians also have some pretty substantive guidelines, and we had a paper released quite some time ago now around managing opiate dependence specifically, and that looks around the safety and efficacy of methadone and buprenorphine in pregnancy, really highlighting that if someone has an opioid disorder and they're presenting in pregnancy, the gold standard treatment is to be on opioid substitution treatment such as methadone and buprenorphine. That is by far and away going to both retain the woman in treatment, but also prevent harm to the baby, and so we know that that's the case. And so in the next couple of minutes, I just want to kind of draw attention to sort of thinking about models of care. And so with models of care for women, there have been a range of different studies kind of understanding this. And the key kind of principles here are really around safety. And when I say safety here, I'm talking about sort of both physical safety, but also trauma-specific safety. So actually having a space where someone with a history of trauma and a woman with a history of trauma feels like they're actually comfortable and safe and able to kind of come in and have their needs met and be able to have a safe conversation with people. Flexibility is important, particularly around sort of childcare, parenting needs as well. and then starting to think about integrated support across kind of psychological, social needs, but also really healthcare needs across the lifespan. So a couple of resources that are really excellent in this space are these pictures that I've kind of gotten from the Tip 51 from the Substance Abuse and Mental Health Administration in the US. This is a lengthy document, it's about 380 pages, so I don't recommend it unless you have problems sleeping at night. Then it might be good bedtime reading. But these appendices right at the back have a really good sort of clarified model around what might work for women as opposed to men. And there are a whole range of different things that clearly would apply for both sexes, both genders. But I think what's distinct here and important to think about is really around the trauma-informed and trauma-specific services. That's not something that we necessarily routinely have embedded in drug and alcohol treatment across Australia, but really is something that's hugely overrepresented in women, and we're going to spend a bit of time talking about that. Now, in terms of clinical treatment services, SAMHSA certainly recommend this, and I think this is a model that Australians work well in the sense of clinical treatment services needing to really be embedded within a broader sort of recovery support network. And that can include a whole range of different social support services. But for women, I think, in the space, and we work variably across this, I think, in different jurisdictions, but being able to have good relationships with child protection, with Child First, with services that support those services such as Anglicare or other services in that space, being able to kind of support the different needs that the mother might present with are really important. Now, the other thing that we, again, don't necessarily routinely address are around reproductive needs and gynecological health. We know that there are actually a whole range of disorders that we don't actually routinely screen for in women who present to drug and alcohol treatment. And women in drug and alcohol treatment don't necessarily regularly see GPs. People in drug and alcohol treatment broadly don't necessarily see primary care specialists all that often. So this is a group that, you know, generally has barriers in terms of accessing primary care. So it's really important that when they do come into a treatment service, and if that happens to be a drug and alcohol treatment service, that we can start these conversations happening around sort of sexual health, endometriosis and PCOS, for instance, or polycystic ovarian syndrome. Again, these conditions might go untreated and missed, and for many people there might be sources of chronic pain that might actually kind of persist and maintain other problems the person has with addiction. I think the other thing in this space is being able to offer people advice, women of childbearing age, advice around contraception, regardless of where they're actually engaging with in the treatment system. So that's an information leaflet that I developed with the Women's quite some years ago now, but really kind of points at some of the myths I think that many people have around sexual health and around contraception use. For instance, many people who are opioid dependent might think that because they don't get their periods regularly, that they therefore might not be able to get pregnant, and that is a myth. And you know, the effect of the opioids might actually be impacting on their menstrual cycle, but that doesn't mean that they may not be able to ovulate at all. And so there might still be a risk of pregnancy. And so it's really important for women to be able to think about that and have an informed decision around that. Now, models of care. For often in many services, the answer to sort of thinking about models of care is, you know, if we want to offer treatment for women, should the treatment be women only? And look, there are lots of opinions on this, and this is an article that came out last year in the biggest addiction journal, Addiction, and was a debate article. And that was a qualitative study. They did a focus group with a number of women and really asked them what their thoughts were about residential treatment. So this is like a rehab setting, whether women would want to be in a women-only rehab. And, you know, I really recommend kind of reading that article, but also reading all of the articles that came in response to that article, which really kind of points out that, you know, the jury's out here. I think it's very much around, you know, this is not necessarily the paradigm for everyone. And I think that's really important in terms of being able to discuss with your patient sitting in front of you what's best for you, you know, what do you think you're going to benefit from, what your preferences is. So I've got a whole range of different responses to that in that space. The last one being Australian, really pointing out that perhaps I need to have a considered debate around this and have more research in this area. Now, the last little bit of our talk today is specifically focusing on trauma, and I've highlighted that this is really an issue that's overrepresented in women. So trauma in substance use treatment settings, we estimate that up to 60% of women getting substance use treatment have PTSD, and that's formal PTSD, so actually having symptoms that meet the criteria for post-traumatic stress disorder. Among women who have substance use disorders, that prevalence is also considered to be 2 to 3 times higher than it is for men. And pointing out that the prevalence of PTSD is again really high for men who have substance use disorders in comparison to the general population. For many people, this is really important because when they start to quit using whatever drug they're currently dependent on, the PTSD symptoms can actually worsen. So for many people, it's a process of self-medication, of use to actually try and manage those symptoms of post-traumatic stress disorder, or even symptoms that don't meet criteria of post-traumatic stress disorder but originate in stress, such as complex PTSD. So here we know that without treating that, we're actually setting up the person to fail in many ways. And because that can worsen in withdrawal and with abstinence. So integrated sort of approaches are really important here, both in terms of a trauma-informed perspective, but also a trauma-specific perspective. And I think the distinction here is moving into a trauma-specific approach really requires sort of experience and sort of training in this space because it can be a really complex area. What's important across the board, I think, in terms of treating trauma in people who have addiction, but particularly in women who have addiction, is thinking about staging that and really kind of having that first phase of really ensuring safety, first and foremost, but stabilization of that substance use patterns before delving into doing more focused work. So a review that came out very recently kind of summarized the literature in this area really well. If people are interested in reading more about it, this study scopes interventions that work for women who have experiences of family violence specifically. And I guess, where this has kind of led us as a service is really starting to think about women's specific services in our own organization and wanting to, embody perhaps that picture I showed you before from SAMHSA, really starting to think about multidisciplinary care for women who present to our services that are integrated and across the lifespan. So not necessarily just engaging with women around pregnancy, but across whole lifespan, including older women who are clearly presenting in treatment more often, but also have a whole range of different needs than younger women. So at the moment where that's sitting is really we're looking at a very comprehensive sort of assessment model with feedback to women and referrers, but we have plans to kind of look at more integrated treatment and trauma approaches as well. So watch the space. So next few slides are really around resources and references, which I encourage you to kind of look up if you're interested. That was the 380-page one you can have a look at, and these are some other resources, including an excellent textbook. It's a bit dated now, but it's still it's the best one out there. And the next to it is probably the best one that's not a textbook, is Jenny Valentish's book, which I really encourage people to go out and look for. There are a range of services that are Victorian that are listed there, including the Women's Drug and Alcohol Service, Regen's Mother-Baby Unit, the Salvation Army's Women-Only Residential Rehab, Bridgehaven, and Swinburne, who have a Women's Trauma Recovery Program as well. We might end there and try to take some questions. So thank you for listening. If you've got any, my email address is there as well if you wanted to email things directly through. I'll just conclude also by thanking Davinia for some assistance with those graphs and Dan is the director of our service. But yeah, we might move to some questions.
Okay, thank you so much, Shalini. Wow, so much relevant information, fantastic resources, and I guess I'm excited about the women's clinic that's maybe coming to Turning Point. Okay, so I'm just going to go back a bit because the questions came in earlier. So someone was asking about, and this question came up when you were talking about advertising in medical journals.
Yeah.
Okay, and so she was asking, to what extent is sexism involved in this area of overprescribing for women?
Yeah,
so.
It's a really good question. Maybe a slightly leading question because I think it probably definitely is. If you look at the age range of those medical journals, probably about in the 1950s, 60s onwards, and certainly there were more male doctors than female doctors at that time for a whole range of other sexism-related reasons. But I think that certainly plays a role in terms of thinking that people needed to be set free from domestic routines, for instance, with benzodiazepines. So, I think this continues to play a role going forward in terms of, understanding what underpins prescription opioid use, what underpins quetiapine use, underpins that interaction in the room with the doctor as well, but what society expects of women and, their capacities and abilities to kind of manage things and what needs medicating, I think.
Thank you. And another question's come through is, what about weight loss as a precipitating factor for methamphetamine use, and has there been any research around this?
It's an interesting question. There is a little bit of literature, but it's really underdone as a research topic. I think in terms of methamphetamine, I mean, the original kind of chemistry around this in terms of amphetamine type substances, they originally started as medications, and they were originally prescribed for weight loss. We're thinking sort of, 10 to 20 years, 20 years ago. And even now there are amphetamines prescribed largely in the US for weight loss specifically for that purpose. So weight loss is certainly a motivating factor for many women who actually end up being dependent on the drug. And then fear of weight gain is again something that can impact on recovery.
Great, thank you. Okay, I think that's all we've got time for today. So I just want to thank Shalini for taking the time out and coming in here, because fascinating, lots of information there. And I also just wanted to let you all know, I know we've had a few messages that people have found this webinar really interesting, but they've had to leave because we sort of understand that most of you are drug and alcohol workers, so you have to see clients and have meetings to go to as well. So remember, you can always catch up on any of the webinars on the Turning Point website. So just go to the webinar tab and you'll find all our past webinars there. And you've got contact details for Shalini if you have any other further questions, or you can email me at Turning Point as well. So so thank you so much for tuning in today, and we hope to see you for our next webinar in late May. And we'll be advertising that soon. So thanks a lot. Okay, and remember there's a feedback survey too if you'd like to complete that. Thanks.
Thank you.